Welcome to the assessment and plan portion of the SOAP note writing workshop. Hopefully, you've had a chance to both write down your assessment and plan or your best stab at it, and then also had a chance to share it with a partner. And now we'll keep on going. Now you guys have a chance to compare it to what one possible assessment and plan might look like. It doesn't mean that all of them will look like this, but this is a sample one that I wrote. And for this patient, you have to start off with a summary statement where you have an 86-year-old male with a history of hypothyroidism presenting with 1 week history of right throat pain and dysphagia, along with a 2 week history of dysphonia. Differential diagnosis includes malignancy with a 40-pound weight loss, 70-pack year smoking history, pain, and dysphagia. Also includes abscess since he has swelling, subacute onset and pain, and also severe hypothyroidism since it can cause dysphonia. And number four, recurrent laryngeal nerve injury causing dysphonia from anatomy, of course. So that's your assessment portion. You'll notice it actually has a differential since we're not sure what it is. And then we move on to our plan portion where you might say you give mini assessments here and your plan afterwards. In this example, it would be a right throat pain with dysphonia is your assessment, and you give a little bit of rationale, likely secondary to possible malignancy versus abscess or nerve injury. Patients a former smoker with a 70-pack year smoking history, also associated with dysphagia with liquids more than difficult to swallow than solids. And then your plan is that you would get a CT soft tissue neck with IV contrast and IV morphine for pain control. Your next problem is hypothyroidism, where your patient has a decreased T4 and elevated TSH, and levels aren't seeming to be acute given the patient has hypothyroidism for 50 years and no recent medication changes. So, severe hypothyroidism has been shown to be a possible cause for dysphonia in the past. And in terms of plan for this patient, increases levothyroxine 25 micrograms a day, obtain outside records for his last TSH and free T4, and consider a thyroid ultrasound and possible fine needle aspiration. For his next problem, he's got anemia. It's an unknown cause at the time. It could be secondary to anemia of chronic disease, maybe some component of occult GI bleed since he has no overt signs of bleeding and given his advanced age. So to work that up, you could do iron studies, follow up outside records for less hemoglobin, and continue to monitor, which is sort of use it in jest because you sometimes write that when you don't know what to really write. Every assessment and plan should include a fluid electrolytes nutrition or FEN and prophylaxis section. In our situation, it would be NPO, nothing by mouth for now, IV fluids, D5 half NS at 100 mLs per hour, and heparin 5,000 units sub-Q Q8 for DVT or deep vein thrombosis prophylaxis. I personally include a whole person care section where I might talk about some social or spiritual aspects of the patient. Here, patient prayer keeps patient going during tough times, and so my plan was prayer offered, and patient was receptive to that. The disposition would be where the patient's headed to next, or what's the plan there, and so admit to medicine on duty, also known as internal medicine. So this is all of it in one slide, and essentially, if you wrote a H&P or admission history and physical, this would be what it looked like: a subjective, objective assessment and plan portion. And so this would be your note. In our next section, we'll be focusing on what you would do the next morning.